Hello. That was some great welcoming music. Welcome, everyone, to the 2024 American Cancer Society National HPV Vaccination Roundtable National Meeting. This week, you'll be joining us for a celebration of 10 years. So get out those party poppers and prepare to be inspired by the work that has been accomplished over the last 10 years in partnership with all of you, and gain knowledge on how we can continue to innovate together and prevent HPV-related cancers. I'm Dr. Michelle Fiscus. I'm a pediatrician and the Chief Medical Officer at the Association of Immunization Managers, and along with Tamika Felder, one of the incoming co-chairs of the National HPV Roundtable. Before we get started, I have a few housekeeping items for you. Throughout the session today, please post any comments or reactions or needs in the chat. Any questions you have for the speakers, please put in the Q&A box. The approved presentations and a recording of today's session will be shared, and please subscribe to our newsletter via the website and our socials for more information and new resources, videos, and more. And before we dive into today's sessions on new and emerging science in HPV vaccination, we want to thank everyone joining us and everyone who has helped us to build the work over the last 10 years. This celebration is for all of us. Next slide, please. So today we have an opportunity to hear from three amazing speakers on new and emerging data in HPV vaccination. First, we will hear from Dr. Kunal Saxena, looking at the potential impact of HPV vaccination initiation at age 9. And then we'll hear from Cassandra Pingali, walking us through the most current NIS teen data. And lastly, we'll hear from Dr. Stephanie Starres, who will be looking at HPV vaccine immune response and research to practice. We will have time for Q&A with three speakers as well. And we'll end the call with a call to action for the after party to end our celebration today. I had the pleasure of celebrating 10 years of the ACS HPV Vaccination Roundtable by interviewing one of the original steering committee members of the roundtable, Dr. Melinda Wharton. Let's watch that interview now. Hi, everyone. My name is Dr. Michelle Fiscus. I'm a pediatrician and the Chief Medical Officer at the Association of Immunization Managers, which is a 501c3 nonprofit that supports the 64 CDC-funded immunization programs across the United States and its territories. And I am excited to bring to you a short interview with the legendary Dr. Melinda Wharton, who is of the immunization program at the Centers for Disease Control and Prevention. It's good to see you, Melinda.
It's good to see you, Shelley.
So let's move right in. How did you first get involved with HPV vaccination efforts?
So I guess I was still deputy director of NCIRD when the HPV vaccination program first rolled out. And, you know, new vaccine recommendations takes a little while for coverage to really get high. It always starts low when things are new and it gets higher over time. And so that's what we expected to happen with HPV vaccine to prevent cancer, totally should happen. And you know, you don't necessarily expect to see it right away, and particularly given how we assess coverage at 13 to 17, but years went by and it just wasn't moving. It just wasn't where it needed to be. And so, you know, we did what we often do in these circumstances. We issued a call to action. We tried to make the case that this was important and people should do it. And more time goes by and we're still not in a good place. And at some point it was just very clear that HPV vaccination, routinely recommended first for girls and then for both girls and boys at 11 to 12, was just not, it wasn't doing what it should do, given that there was a routine recommendation for kids in the United States. And this is a vaccine to prevent cancer. Like, why were we in such a bad place? So it really became a major focus. Not just for me, but for a bunch of other people at CDC, to try to work with partners, work with different stakeholders, understand what was going on, and really trying to turn things around.
So did you get to a point where you felt that maybe HPV Roundtable had started to turn things around? Was there a period where you felt like, okay, maybe we're starting to get a little bit of traction here?
Oh, well, I mean, we clearly did get traction, but to be clear, the HPV Roundtable came out of this effort to um, to really do everything we could think of to do to improve HPV vaccine coverage. And the roundtable really came out of, as I recall, a suggestion from Dr. Ann Schuchat, who was Senate director at the time, who I think was familiar with, one of the other roundtables that ACS hosted. And I think that's where the basic idea came from. But, the roundtable was one of a number of initiatives that CDC funded back when we first started really trying to work in this area in order to do what needed to be done to really get HPV vaccine coverage where it needed to be.
When you think about the different campaigns that the roundtable has done around HPV, are there any that have really kind of stuck with you as memorable? And if so, which one and why?
So there's a couple of things the roundtable did that were that seemed to me to be especially impactful. The first was, I think one of the first initiatives the roundtable did, and somebody can correct me on this if I'm wrong, but the action guides were put together. There were action guides for, I think, small and large practices and different clinical settings, and there was an action guide for health systems. And it was really in working with the roundtable as well as with ACS that I think I came to appreciate the real strength and opportunity of health systems engagement in doing something like trying to improve immunization coverage. It was a strategy that was very valuable. It was one that we had not really undertaken before. I think we've, of course, done a lot of work with providers over the years, but not really so much with health systems at that time. And of course, with the consolidation in the healthcare system, clearly a far more efficient way to get information to and work with the providers who really can make the difference, as well as, health systems having the quality assurance teams, the IT capacity, and hopefully being willing to use a little bit of leadership capital to make things happen. So that was one that early on was it really seemed to me like a very valuable strategy, and I think it absolutely has played out that way. The other thing that that really made an impression on me, and of course this was an area that I ended up working on quite a bit, was the state level roundtables, the encouraging the sort of similar groupings of stakeholders that would really allow clinicians and advocacy groups and the cancer and the ACS staff, the cancer center in the jurisdiction, maybe the state cancer program, the pediatric community, the different players to come together and really develop a strategy for how to improve HPV vaccination in their jurisdiction. In fact, I remember texting you in one such meeting
Yes,
many
you did.
years ago. Um, but that was, I think those were just very, very impactful because those were the people really who understood what was going on in the jurisdiction, what strategies would work, what the assets were that could be brought to bear. It really seemed to me to be a really valuable approach.
And all these years later, I think that's still one of the most valuable approaches we have, is just getting all the players at the table to talk about it. Lock them in a room and say, fix it, and do what you
Yeah.
need to do in your particular state. All the states are so different. What do you think's been the biggest hurdle with HPV that we've been able to overcome in the past decade?
Well, I think the all of the work on understanding what was going on with provider communication and developing strategies to address it so that providers actually were comfortable making a strong recommendation, that they were comfortable with talking about HPV vaccine just the way they did about Tdap and meningococcal conjugate vaccine. That seems to me to have been a huge hurdle. And it is one where a lot of people worked on it. There were, a lot of work on how to do it, how to train providers to do it, and a lot of sort of personal testimonials that I think really helped get providers comfortable with making that type of presumptive recommendation for HPV vaccination. I remember being somewhere giving a talk and doing the usual thing about making a strong recommendation and talking about it just the way you do these other vaccines, and somebody in the audience saying that she had, she'd heard this and she figured she'd try it. And the first time she did, she, made this statement about, your child's 11 now, so it's time to get whooping cough vaccine and vaccine to prevent HPV cancers and a bacterial meningitis vaccine, and then expecting pushback from the parent, expecting a lot of questions, and the parent just said, okay. And which I think probably was many providers' experience once they started doing this. So that really was, I think, huge.
Yeah, definitely huge. So if you could tell everybody who's watching, what's the one call to action around HPV vaccine, what would that be?
Well, I've got kids who are young adults, and my children just happened to be born right around the time that they were in, the oldest was in the earliest cohort of girls, um, uh, for whom HPV vaccine was recommended. And I just can't, I cannot imagine not having gotten my children vaccinated. And so I think the one thing I want everybody to think about is who in their life has kids who are, of the age where they should be getting HPV vaccine. And, if you've never talked about it with their parents before, bring it up, just ask. There's, yes, provider recommendations are really important, but the people who are participating in the roundtable are very well informed, and I'm sure they're very influential among their friends and family. And so, ask around, tell people why it's important. I can't imagine not having vaccinated my children, and I want everybody's child to have that same protection that my children do.
That's excellent advice. I feel the same way. I can't imagine not having vaccinated my kids who are now young adults. So it's so important. All right, the next few are just for fun. So these are would you rather questions, Melinda. So, first off, coffee or tea?
Oh, coffee.
Okay, so pumpkin spice or not so much?
Not so much.
Yeah, I'm with
Just
you on that.
coffee, coffee.
Cats or dogs?
Dogs. Although
Thanksgiving
cats are fine too, but
Thanksgiving turkey or ham?
turkey.
Fly or drive?
Fly.
And this one is very polarizing. Cilantro, yes or no?
Oh, yes. I love cilantro.
Oh, I'm such a hard no on that.
It's genetic, it's genetic. You can't help
Yeah,
it.
I'm so crazy. All right. Well, it has been wonderful talking to you, Melinda Wharton, just queen of vaccines and all things immunizations. Thanks for everything that you have done and continue to do to help people get vaccinated all across the US. And thanks for taking a few minutes to talk with me.
Well, thank you. I enjoy talking to you.
I really enjoyed having the opportunity to spend a few minutes with Melinda, so I hope you enjoyed that too. Well, we're going to switch to our speakers for today. So we're joined by three amazing speakers. So please join me in welcoming Dr. Kunal Saxena, Director of Outcomes Research for HPV Vaccines at Merck, Cassandra Pingali, who's an epidemiologist with the Immunization Services Division at the National Center for Immunizations at the CDC, and Dr. Stephanie Staras, Professor and Associate Chair of Faculty Development, Health Outcomes, and Biomedical Informatics, and Program Co-Lead for the Cancer Control and Population Sciences at the U.S. Cancer Center and Associate Director for the Institute of Child Health Policy at the University of Florida. And Dr. Saxena, I'm going to turn it over to you.
Thank you. Hope you guys can hear me okay.
We can.
Excellent. So thank you for a wonderful interview with Dr. Wharton. I really enjoyed her perspective and listening to her, like all of you. Again, appreciate the opportunity to be here and present some of the work we are doing in the age 9 initiation space. So I'm going to be talking about some of the studies and the data we've generated recently that shows the excellent impact that initiation at age 9 could potentially do in terms of U.S. HPV vaccination coverage. So next slide, please. So this is a background slide, and again, I think all of you on the call today, I don't need to preach to choir. Everyone knows that there's growing body of evidence that suggests several implementation benefits associated with initiating the vaccine series at age 9. Some of those benefits are listed on the slides: higher completion rates by age 13, ensuring protection well before sexual debut in certain proportions of the population, focus on cancer prevention, certainly that's a big one, and potentially reduce any kind of hesitancy due to perceived association between vaccination and initiation of sexual activity. There's also a wonderful study published by Dr. Perkins that shows that it's also more resilient in case there is a disruption. COVID is one example, but could be several other reasons, as it still provides ample opportunities to get the second dose in within the desired time frame. And another one, which is beneficial for a lot of health plans and insurers, that they achieve the HEDIS measure that is drafted by the NCQA for quality metrics. And the HEDIS measure for HPV immunization is defined as completing of the HPV vaccine series by individual's 13th birthday. So all those benefits are really tremendous, and because of that, and the AAP and ACS endorsed initiation of HPV vaccination at age 9. Next slide, please. So as I said, now I'm going to be talking about two of the studies that we have done recently. One is published, as you can see on your screen. It was recently published in the Journal of Frontiers in Pediatrics, and it's a modeling-based study that assesses the long-term implications of age 9 initiation of the vaccine series, and the impact is, assessed in age 13 to 15. So it's the projection from an age-structured vaccination model. What essentially it's doing is looking at, initiation at 9, comparing it to initiation at 11, look forward in the future, 20 years down the line, and see what could the future look like in terms of initiation at 9, and then comparing it to status quo, which is what's happening right now, which is more sort of initiation at 11, and very little initiation happening um, at 9. So next slide, please. So these are the two scenarios that we compared in our model, in our modeling exercise. First scenario is status quo, which is right now there's no change in initiation of HPV vaccination at age 9. It assumes whatever initiation at 9 is happening, currently, which is less than 2 or 3% based on the NIS teen data, which was the data source for this modeling exercise. And then it was compared against the second scenario, which is the proactive initiation, which is simulated gradual increase in 9-year-old, more and more 9-year-olds getting their first dose at age 9. And that number, that proportion increases by 5% each year. So what increase happens every year. Next slide, please. So this is the result from the first scenario, the status quo. So after 20 years, this is what the the outcome will look like. So you can see the initial proportion of vaccination status across age groups. So a lot of those people are still in the blue boxes, the blue histograms. These are the groups with 0 doses. And as you can see later down the line, as one grows older, you can see some people with 1 dose, some people with complete series, full protection. But it takes almost a long period of time to get there. And then similarly on the right side of the slide, you see the desired coverage level, which is 80% according to the CDC healthy people goal. It was not achieved until 2043. So 20 years down the line, you will not, at least the model shows that we are not going to get to that 80% coverage level in 20 years. Next slide, please. This is the proactive initiation scenario, which is more and more age 9 each year, 5%. As you can see, it's a significant difference in coverage levels. More and more, those dark green boxes, which indicates people with their full series completed. And on the right side, the coverage of 80% was achieved between 2032 and 2033, which is right off the bat, 11 years or 10 years, reduced compared to the earlier scenario, which is status quo. So you can see that we can, in about 10 years from now, we could actually realize that 80% coverage goal in adolescent 13 to 15 years of age in the US, at least based on this NIS data, teen data driven modeling exercise. So I know I have been given a warning, so I'm going to try to move it a little faster. Next slide, please. This is just a slide that shows the relationship between time to get to that 80% coverage level and its association with the increase in the initiation rates. So what this slide is showing that the relationship is not linear. So the highest impact on the reduction in time to get to that 80% coverage level will come in the initial few years of those age 9 initiation, because initial increments matter the most. Once you start getting more and more people vaccinating early, then they will start accumulating up and add to the overall 80% coverage level. So initial increments, whatever they are, 2%, 3%, 5%, that have potentially the biggest impact on coverage. Next slide. This is the second study where we analyze market scan data, which was for both commercially insured population as well as Medicaid insured population. And these data were presented at the NIC meeting in Atlanta a few weeks ago, and then we are also planning to publish it very soon. Next slide, please. So what we did was, in this analysis, we looked at the adolescent with their annual well visits. And again, we did it for both the commercial and Medicaid population. We looked at annual well visits for age 9, 10, 11, 12, 13, and 14 from years 2018 to 2022. So we really wanted to understand the trends of well visits and then the concurrent vaccinations happening during those annual well visits. So this, slide shows you the trends of well visits that were happening, and you can see Medicaid on the right side. That population has significantly lower well visit consistently across all the different age groups. Next slide, please. This is the average number of concurrent vaccinations in adolescent at well visits in the privately insured population. The trend is similar in the other population. So, in interest of time, I'm just going to be talking about the results of the privately insured population. So as you can see, age 9, almost 90% have 0 concurrent vaccinations happening. Comparing it to age 11, as you can see, 37% or more have more than 2, and 35% or more, or around 35% people have around 3 concurrent vaccinations happening. So clearly there is a difference, and there's an opportunity to vaccinate, initiate the HPV vaccination at age 9, because there's very little vaccination happening at that stage. Next slide. These are the types of concurrent vaccinations that are happening during those annual well visits. So again, as you can see at age 11, it's predominantly meningococcal Tdap vaccination. HPV initiation is in that yellow bar, which is, in terms of number, they were less than 20% at age 11 that was happening. So that's the main takeaway from this slide. Next slide, please. And this is the, a very important table. I would say this is like the money table from our analysis. As you can see, this table exactly tells you the potential opportunities. So among adolescents with well visits at age 9 or 10 who did not receive the HPV vaccination at their age 9, 10 well visits, 35%, around 35% and 37% did not have a well visit at age 11 or 12. So that was a big missed opportunity right there, because these are like almost a third of the population that did not come back after coming in for their well visit at age 9 and 10, did not come back for their well visit at age 11 or 12. Then, some of the other missed opportunities are adolescent with well visit at 11 or 12. Around 20 to 30% received 1 or more vaccination, but not the HPV vaccination. Then similarly, adolescents with a well visit at age 11 who received 1 or more vaccine, but not the HPV vaccine, came back at 12. And out of those, 67% or so did not again receive the HPV vaccine. And then finally, among adolescents with well visit at age 11 or 12, who received 1 or more other vaccination, but not the HPV vaccination, out of those, around 40 to 54% had a well visit at age 9 or 10. So those are all the missed opportunities that were quantified in this analysis. So I know I'm out of time. Maybe I can just quickly go to my last slide. Maybe that's this is my conclusion slide. So as you all know, we have had the pandemic had a sustained disproportional impact on HPV vaccination in the US. Our research shows that, age 11 platform may be working well for, some adolescent vaccination, but it's not showing the same success for HPV vaccination. And the same research shows that, there's a lot of opportunities that could be utilized to improve that HPV coverage rate in the adolescent. And, these findings demonstrate how it is easier to implement age 9 initiation, routine vaccination at age 9 could be the much needed solution to help the long-standing problems of HPV coverage rates in the US, and then reduce the risk of HPV-related disease and cancer burden. So I'm going to end here. Thank you. And I'll give it to Sandy. I was supposed to do that. Sorry, Sandy.
That's okay. Thank you. Well, thank you, Dr. Saxena. Hi, everyone. My name is Sandy Pingali, and I'm an epidemiologist at CDC, and I'm the subject matter expert for a survey called the National Immunization Survey Team. Today, I'll be reviewing the latest vaccination coverage estimates from the 2023 National Immunization Survey Team data, with an emphasis on HPV vaccination coverage. And these data were recently published in CDC's Morbidity and Mortality Weekly Report on August 23rd. Next slide, please. So I'll start with a high-level summary of the National Immunization Survey Team, or NIS team. So the NIS Teen Survey is one of the tools that we have to monitor vaccination coverage among children in the United States, and specifically focuses on coverage among adolescents. So the NIS Teen Survey consists of two phases. The first phase is a random digit dial telephone survey of households with teens aged 13 to 17 years. And then the second phase is a mailed survey of vaccination providers. The household survey collects sociodemographic information and requests permission from the parent to contact the teen's vaccination provider. So if permission is granted, then a mailed survey is sent to all vaccination providers identified by the parent. And then the provider survey collects data on the teen's vaccination history, including when vaccinations were received, which types of vaccinations were given, and how many doses the teen has had. And vaccination providers can be any place that has administered the teen a vaccine, including primary care offices, pharmacies, or health departments, for example. And the 2023 NIS Teen surveyed 16,568 parents or guardians of teens who were born between January 2005 and December 2010. Next slide, please. So just a few quick methods notes about the 2023 data. So recent NIS Teen reports present coverage results by both survey year among adolescents aged 13 to 17 years and by birth year at specific milestone ages. And we added birth year analyses to capture changes in vaccination coverage among birth years who were due for routine vaccinations during the COVID-19 pandemic. So the teens who were due for the routine adolescent vaccinations during the pandemic were born in 2008 and 2009, and they're now 14 and 15 years of age in the 2023 data. And the 2023 data also includes the first birth cohort whose routine vaccines were administered after the COVID-19 emergency had ended. This would be the 2010 birth year, and they were 13 years of age in 2023. And then those born in 2005 to 2007 were due for routine vaccinations before the pandemic. And so therefore, the pandemic would have likely had little effect on vaccination coverage among these birth years. And understanding which birth years were due for routine vaccines during the pandemic will be important for understanding the pandemic effect analyses that I'll present later on. Next slide, please. But first, we'll review the cross-sectional coverage estimates among adolescents aged 13 to 17 years from the 2023 data. We'll look at the overall trend in coverage and data stratified by sociodemographic factors. So this line graph shows the trend in coverage with the 3 vaccines routinely recommended for adolescents, including the Tdap vaccine, the meningococcal ACWY vaccine, and the HPV vaccine from 2006 to 2023. And 1 or more doses of Tdap is the red line. 1 or more doses of ACWY is the dark blue line there at the top of the graph. And coverage with these vaccines has been high and stable around 90% since about 2018. And in 2023, 77% of adolescents aged 13 to 17 years had initiated the HPV vaccine series, and that's shown in orange. And 61% were up to date with HPV vaccine, which is shown in green. And we know that we can reach higher HPV vaccination coverage because Tdap and ACWY coverage are near 90%, and they are the other 2 vaccines routinely recommended for adolescents. And we had seen steady increases in HPV vaccination coverage over the previous decade, but coverage has stagnated in 2022 and 2023. Next slide, please. So this figure compares routine vaccination coverage by MSA status. MSA principal city or mostly urban areas was the reference group for comparisons. Urban areas are shown in gray, suburban areas are shown in blue, and rural areas are shown in red. HPV vaccine initiation and the percent of adolescents who are HPV up to date are lower in mostly suburban and mostly rural areas compared to mostly urban areas. So 80.1% of adolescents aged 13 to 17 years who live in urban areas had initiated the HPV vaccine series, compared to 74.8% in suburban areas and 72.5% in rural areas. Next slide, please. And then this slide compares coverage with the routine vaccines by health insurance status. Privately insured adolescents were the reference group for comparisons. And adolescents with private insurance are shown in gray. Any Medicaid is shown in blue. Other insurance types are shown in red, and those without health insurance are shown in green. And overall vaccination coverage was lower among uninsured adolescents compared to privately insured adolescents for all vaccines recommended for adolescents. And we've seen that pattern for many years now. Those with other insurance, they had a lower percent HPV up to date compared to privately insured adolescents. And we'll examine coverage with private insurance and any Medicaid insurance more closely on the next slide. Next slide, please. So historically, adolescents insured by Medicaid had higher coverage with one or more doses of HPV vaccine compared to privately insured adolescents. And you can see that the blue line for coverage with one or more doses of HPV vaccine among adolescents insured by Medicaid was higher than the gray line for privately insured adolescents from 2015 to 2021. And then in 2022 and 2023, adolescents with private and any Medicaid insurance had similar coverage with one or more doses of HPV vaccine. And last year, when analyzing the 2022 data, we found that coverage with one or more doses of HPV vaccine had declined among Medicaid insured adolescents by about 3 percentage points. And this was a concerning finding because we want to maintain high vaccination coverage, particularly among under-resourced communities, and we want to ensure equitable access to vaccine. Next slide, please. So this figure shows routine vaccination coverage stratified by race and ethnicity groups, and white adolescents were the reference group for comparisons. And this year, there weren't many differences in coverage by race and ethnicity. Historically, Black and Hispanic adolescents have had higher coverage with one or more doses of HPV vaccine compared to white adolescents. But in 2023, only Hispanic adolescents had higher coverage. Next slide, please. And then this figure shows the importance of receiving an HPV vaccine recommendation from a provider. The dark blue bars show HPV vaccination coverage with a provider recommendation, and the light blue bars are HPV coverage without a recommendation. And in 2023, HPV vaccination initiation is about 20 percentage points higher among adolescents whose parents reported they received a provider recommendation compared to adolescents who recommendation. Next slide, please. So HPV vaccination coverage continues to vary widely by state. And this map here is showing coverage with one or more doses of HPV vaccine split into quartiles. And the overall US coverage with one or more doses of HPV vaccine was 77%. And we found that Mississippi had the lowest coverage at 60%, and Rhode Island has the highest coverage at 93%. Next slide, please. So now we'll discuss the pandemic effect analyses, which looked at coverage by birth year. Next slide, please. So this figure shows coverage with routine vaccines by age 13 years and by birth year. The gray line is Tdap, the blue line is been ACWY, the red line is HPV initiation, and the green line is HPV up to date. And then the x-axis is birth year, and the figure is examining the coverage achieved by each birth year by age 13 years. And at age 13 years, we would have expected adolescents to have received Tdap and been ACWY vaccine and finished the HPV vaccine series according to the ACIP schedule. So in this analysis, the 2007 birth year is our reference birth year for comparisons. This birth year achieved the highest level of coverage seen before the pandemic, and they were 13 years of age in 2020. And by age 13 years, coverage with one or more doses of Tdap, one or more doses of ACWY, and one or more doses of HPV vaccine was 2 to 3 percentage points lower in the 2008 birth year compared to the 2007 birth year. And then coverage among the 2009 birth year was similar to the 2007 birth year. And then among the 2010 birth year, we do see that HPV up to date was 7 percentage points lower compared to the 2007 birth year. And this may be due to the small sample size for this birth cohort in the 2023 data. It may have been a lingering pandemic effect, or it may have been a sampling issue. Next slide, please. So now we'll look at vaccination coverage by birth year and eligibility for the Vaccines for Children program. This line graph is showing routine vaccination coverage by age 13 years among the 2002 to 2010 birth years, among those who are eligible for the VFC program in solid lines and those not eligible for the VFC program in dashed lines. And if we focus on just the HPV results, which are the red and green lines, prior to the pandemic, HPV vaccination coverage was higher among VFC eligible teens compared to non-VFC eligible teens among the 2002 to 2005 birth years, but then coverage was similar among the recent 2006 to 2010 birth years. And this may indicate that access to the VFC program has changed during the pandemic in some way, and it may now be harder for eligible families to get their teen vaccinated. Next slide, please. Okay, so we've reviewed a lot of data today from the 2023 NIS Teen Survey, but these are the 3 key points from the data that I hope everyone will remember. First is that HPV vaccination coverage has not increased among adolescents aged 13 to 17 years for the 2nd consecutive year. Second is that prior HPV coverage advantages among adolescents eligible for the VFC program are no longer evident after the pandemic. And then finally, the percent of adolescents who are HPV up to date declined among the most recent birth cohort surveyed in NIS Teen compared to the last pre-pandemic birth cohort that we surveyed. Next slide, please. So just a quick thank you to my team and colleagues at CDC, and thank you to the Roundtable for having me here today. And I'll now turn things over to Dr. Staras for her presentation. Thank you.
Thank you so much. I'm really delighted to be here today, and I'm going to be talking to you about HPV vaccine immune response and research to practice. Next slide. So I have 2 main points. First, we'll be covering the immune response to HPV vaccination, and then talking about how we can take some of these research and move it into clinical practice. So I will cover some of the evidence-based interventions, as well as tell you about an example study. Next slide, please. So first, to talk about the immune response to HPV vaccination. Next slide. We'll begin with our HPV vaccine recommendations. So many of you likely know this, but I wanted to review that the Advisory Committee on Immunization Practices, also known as ACIP, currently recommends HPV vaccine 9 for ages 9 to 45. The 9 to 10-year-olds, ACIP states that this can be given at this age. And the American Cancer Society and the American Academy of Pediatrics strongly recommend that we begin vaccinating at 9 to 10. The 11 to 12-year-olds is the age that ACIP recommends for universal coverage. So to make sure that by 11 to 12, everyone has received the vaccine. And ACIP considers 13 to 26-year-olds as late vaccination. And then for 27 to 45, can vaccinate with shared clinical decision-making to evaluate the risks. Also like to point out the difference in dosing recommendations by age, which are primarily based on the immune response. And some of that I'll be showing you next. So first, if you initiate the vaccine before your 15th birthday, you require 2 shots, and these can occur over a 1-year time period. And if it's after your 15th birthday, you need 3 shots within a 6-month period. So next slide, please. So then I wanted to show you some of the data on the effectiveness of the HPV vaccine against HPV infections. So this data is from a systematic review by Ellingston and shows 4 studies. And since you may not all be familiar with the systematic review, I'll explain this chart to you. So we have this dashed vertical line shows the odds ratio or risk ratio of 1, at which point the vaccinated and unvaccinated would have similar levels of HPV infections. Everything to the right side would show that the unvaccinated are less likely to be infected, but everything to the left shows that the HPV vaccine is more effective than non-vaccinated, which is not a surprise. But I also want you to see that not only do all of the study estimates fall to the left side, and I wanted to stop and tell you that the dots are the point estimates and the lines are our confidence intervals. And the top 3 studies show 2 age groups. So they show greater than 18 years old and less than 18 years old. You can see in each of these studies, there is a increase in the protection. So it goes further to the left in the younger age group. And then the most telling for this conversation is the Kavanaugh study in 2017 that does a 1-year age range. And we can see that the vaccine protectiveness against HPV infections increases with every decreased age of starting the vaccine. So this is a beautiful kind of stepwise piece where we see that each year earlier, you receive more protection because the immune response is higher. So next slide, please. This same systematic review also looked at some of the HPV outcomes, and one of them is cervical abnormalities, which I wanted to show because it has the most studies. And here again, we see that all of the studies show that having the vaccine is more effective than not for signs of cervical abnormalities. And each of these studies looks at the age. So for example, in the first one has greater than 21, 18 to 20, and then 14 to 17. And you can see there's a small stair stepping where it's getting more protective as you receive the vaccine at a younger ages. Again, if we look at the middle study, which is Palmer 2019, they did the 1-year age breaks of 18 and then all the way down to 12 to 13. While this is a little less clear than we saw for HPV infection, we can see that the protection is increasing for cervical abnormalities the younger and younger you receive the vaccine. Next slide, please. So when we start to talk about receiving the vaccine at earlier ages, we really need to think about, well, how long is this vaccine going to be protective? So I'm showing you data from Schwartz's study in 2019, which looked at the HPV 16 and 18 vaccine and took the cohort that was in the trial and followed them over time for 120 months or 10 years. So what you see on this chart is the line with the X's is the girls in the study that were aged 10 to 14 when they received the vaccine. And this chart shows the geometric mean titer, which is basically the immune response to the vaccine. You can see that it immediately kind of goes up very high, peaks and goes down around 12 months, and then kind of stays steady, but maybe with a slight decrease over that 10-year period. What I love about this study is they give us 2 references. So they referenced this solid black line is the estimate of the geometric mean titer at 9.4 years among girls that received the vaccine at ages 15 to 25. So they're a little bit older. You can see they still have a strong, durable protection, but it's a little lower than the group that received the vaccine at a younger age. And then finally, they compare this to the blue line, which is the natural infection among girls who are 15 to 25. So in summary, what we see is that not only at 10 years is there still protection, but it's even more protection in the girls who were vaccinated at the youngest ages. And this is also repeated in HPV vaccine 9 study as well. So if you could go to the next slide, please. Then we also I wanted to show you that this same study by Swartz did some modeling to predict at 50 years what would be the protection from the HPV vaccine. And they did this for HPV 16 as well as 18. I'm showing you 16 for brevity. They have two models. One is a piecewise model where they had, the sharp increase with the decrease and then showed maybe a decreasing effect, a very slow, gradual decreasing effect over the 50 years. But you can see that at the end of 50 years, there's still quite a bit more protection from the vaccine than even the natural infection. And then they did a modified power law model where they kind of kept more of a steady state after the first couple years. And you can see that the protection is significantly higher at 50 years. While these are modeling studies, we have seen similar protection from other vaccines. Could you go to the next slide, please? So now in my remaining few minutes, I will tell you about, now that we have reviewed all of this information about how it's necessary to get younger ages vaccinated, some research to practice. So next slide, thank you. This slide has recommended research-based practices to increase HPV vaccination. These are all evidence-based, which means that they've shown to be effective to increase HPV vaccination. And you can find resources for all of these on the American Cancer Society HPV Vaccine Roundtable. And to tell you a little about them, they're grouped in 3 different categories: the patient-directed, the provider-directed, and then access to care. And what's most recommended is you do a multi-level approach. So you pick interventions that target the different groups. So for example, I could pick a patient-directed intervention and do client reminders. And at the same time, I would pick a provider-directed intervention and maybe train my providers to make sure that they know how to offer a strong recommendation. We just saw was so effective in increasing vaccination rates. And then maybe I would add evening and weekend hours to allow some more access to care. Next slide, please. Then I wanted to tell you about a real-world example of our study where we did reminder recall with text messaging. This was a study of 30 clinics in which they sent text messages to 2/3 of their parents of 11 to 12-year-olds. And what I'm showing you on this slide is our process measures. So first we sent 4,270 text messages over a year period, and we could confirm that 74% of those messages were delivered. And we can't know for sure if they were delivered to the right family because someone else might have that cell phone number now, but we do know that they were indeed delivered. We also know that 6% requested an appointment. And most of these requests were when we used the bidirectional text messaging that allowed families to respond immediately to the text, but we also had some phone call requests. And then finally, we did a survey where we asked parents who were sent the texts if they remembered receiving them. And among those that participated, 75% remembered. So what I wanted to show you on this slide is that you will most definitely lose people at each stage. And when I talk to clinics, they often say things like, well, I know my addresses aren't quite right, or our phone numbers aren't right, or people don't always call when we do this. And I want to say to that, absolutely, that was 100% true. If you're going to be doing reminder recall, you're going to lose people in every step of the way. But it's still important. And so I want to show you the next slide that shows you what we found. So even with all of these areas where we lost people throughout the way, we found a risk ratio of 1.17, increased vaccination among 11 to 12-year-olds from those who received text messages to those who did not So we had a 6% increase in vaccine initiation, which was actually quite remarkable. For the text messaging was really easy for the clinics to do. So I hope you can find a strategy that works for your clinic. If you go to the next slide, please. I just want to say thank you, and I'm happy to take your questions as we move into the next phase.
Great. Thanks so much to all of our speakers, and we are going to move into a question and answer session now with all of our speakers. We do have a few questions that have been popped into the Q&A. And so I will start with this first one, which is for Dr. Saxena. So for many looking at outcomes data for clinics pushing age 9, there's been a question on how to compare those who vaccinate early versus later. How do you assess the difference between those who are age 9 to 11 and vaccinated versus those who are age 11 to 13 and vaccinated? So in other words, couldn't those who vaccinate earlier also be those who would have vaccinated at 13?
So if we're going to look at age 13, first of all, thank you. That's a very good question. But if you're going to look at the cutoff of age 13, there's enough data to show actually if you start vaccinating at 9, you have almost 3 to 5 times higher likelihood of completing a series by age 13, because you have multiple years compared to if you start at 11. For some reason, you're not able to come back at age 12 to get your second dose, then you just have to come back before you turn 13 to get your second dose. And a lot of times that's not happening. And then there's plenty of data to support that hypothesis. There's studies that have looked at NIS teen data. There's studies that have looked at market scan, claims data. So by age 13, definitely, there's higher chances of completing a series if you start at 9. If you're going to go beyond 13, let's say you want to look at age 15, then yes, there could be some people who might start at 11 and get your second series or second dose or complete your series at age 14 or 15. So now there are few things here, right? I mean, do you want to wait to get fully protected by like a later age? Because there are several benefits of completing your vaccination series by age 13. That's why it's also a HEDIS measure. It's a quality metric in the US. So, a lot of benefits of completing, your series by age 13. And then one of the research we recently did, and I presented some data, I couldn't spend much time because I was, running out of time, is that when we look at those concurrent vaccinations, happening during the well visits, one of the striking findings from that research that surprised all of us was that almost a third of those adolescents are not coming back who came for their age 9 and 10 well visits. They did not have a well visit recorded at age 11 or 12, which is a big chunk of the population. So that is a big opportunity to get them their HPV vaccination at age 9 and 10 and not wait, because they can come back and get it later, because they're not going to come back. At least that's what the data shows. Especially for Medicaid insured population, because one of the other findings from that analysis also showed that the Medicaid well visits were around 45 to 47% compared to the privately insured population that was like around 75%. So for those children, especially that age 9 well visit, that should definitely be utilized to get them started on their HPV vaccination series. So I don't know I hope that answers the questions.
Do you have any thoughts about why that large chunk of kids isn't coming back to 11 and 12? Because almost every state has school-based vaccination requirements at that age. So how is that happening?
Well, so I mean, that's a third of the cohort we looked at. So there is like around 70% or so that are coming back for age 11. We are hoping that they are coming back for age 11 and 12. But again, there could be many reasons, and I don't want to sort of speculate because you'll have to go into the weeds, talk to the providers and parents, why is it happening? Maybe, it could be logistical reasons. It could be, that they don't feel the need to come back for 11 and 12 months, because you do have other vaccinations that are recommended right now for age 11. But again, they could sort of deprioritize it, decide to come back the year later. So again, we will have to do further research to understand, why is that happening. But again, like I said, I think 70% or so are still coming back, but that 35% is a big chunk, which is not coming back.
Yeah, it's a lot. Did you have in your data if those kids that didn't come back received the other required or that Tdap and meninge, or did you not? Do you not have that information?
So for those people who did not come back for 11 and 12, did they receive their Tdap and meningococcal?
Right.
We did not specifically look for that information, but again, if they're not coming back at age 11 and 12, then they probably are missing those vaccinations as well, if they're not receiving it earlier. So I'm hoping that, if we were to dig further, we could probably track them down and see when did they actually receive, if they received their other vaccinations.
Right. Great. Thank you. For Cassie, are all of the states participating in the NIS surveys, or are there some states that aren't now?
All 50 states participate in the NIS surveys. And then we have a couple of local areas. DC participates, and then Guam, USVI, and Puerto Rico participate.
Great. And also for you, can you clarify in the data what is included in other insurance?
Yes. So other insurance is CHIP, military, Indian Health Service, and then any other insurance type that is not private or any Medicaid.
Okay, great. Thanks for that clarification. There were a couple of questions about vaccinating older adults. I'll give this to whoever wants to answer. If someone starts the series before age 45, but they don't get it finished, can they finish the series after age 45?
What was the question again?
If someone starts the series before age 45, but they don't finish the series, can they go ahead and finish it after age 45?
I probably wouldn't know the answer to that. I know that you can finish your series until age 45. Doesn't matter when you start, it just the number of doses are different. But if someone starts, like, let's say at 44 or so, and then waits till they're 46, then I don't know. We'll have to look back at the guidelines.
Great, thanks. Let's see. This is for Stephanie. Can you clarify that the increased protection from HPV infection and disease at younger ages is most strongly related to getting vaccinated prior to exposure rather than higher antibody titers? Immune response is high enough at all recommended ages, but effectiveness relies on vaccinating prior to exposure. Can you comment on that?
Sure. I don't think any of the studies I looked at really address that in particular. I think it's probably both. We know the immune response is stronger at the younger ages. That's why the recommendation is you only need 2 doses before age 15. But certainly if you are vaccinated before you are exposed, then that's also great.
Great. So a couple of comments just have come in from the chat. So from Heather Brandt, yes, you can get vaccinated after age 45, but it's off label. And so you're probably going to pay out of pocket for that because your insurance is likely to not pick it up, but there aren't any safety risks that are known for getting vaccinated after age 45. And then someone also commented that Europe does not have an upper age limit for vaccination. So hopefully that answers that question. One more time, Cassie, the other insurance was CHIP military IHS and
That's right. So it's CHIP, Indian Health Service, military insurance, and then any other insurance type that was mentioned that was not private or Medicaid. So it would go into that other bucket.
got it. I'm sorry, I called you Cassie, Sandy. Okay, a few more questions here. This is for Sandy. What are your thoughts on why the private group is not doing better for HPV vaccine, since we often see that with other vaccines?
So that is such an excellent question and something we have thought about, when we see these data up until recently that were showing any Medicaid, adolescents with any Medicaid insurance had higher HPV vaccination coverage compared to privately insured adolescents. And we don't know why HPV is special. This pattern is probably being seen. We think it's a strength of the Vaccines for Children program. So families are eligible for the Vaccines for Children program if they are on Medicaid insurance, if they're uninsured, if they are American Indian Alaska Native, or if they're underinsured and their insurance won't pay for vaccines. So we think these Medicaid eligible teens are able to access free HPV vaccines. And so maybe that's why we're seeing the higher coverage. But it is definitely an interesting pattern. And yeah, we think it's probably something to do with the VFC program.
Great, thank you. Back to Kunal, and by the way, if you have questions, please go ahead and put them into the Q&A and we will ask those here. For Kunal, your modeling simulation allows users to understand the impact of their interventions and increases for HPV vaccination within their systems. Can you talk to the impact of on-time HPV vaccination?
So if I'm understanding the question correctly, you're talking about completing the series by age 13. What is the impact of doing that? So like I said, I mean, in one of the slides I showed early on, there are many benefits, and I think I sort of talked about it a little bit in my first response. Also, that there's a reason that the NCQA has completion by their 13th birthday as one of the HEDIS measures for HPV series vaccinations. So, again, there's more resiliency, in the vaccination program, because, you can get full protection before, exposure to HPV, because as you grow older, there's a higher chance of higher likelihood of, sexual exposure, sexual debut. There's also data that shows that the well visits reduce or decrease after a certain age. So like, after 14 or 15, you can see the trend of well visits kind of going down because, children are now getting into that younger adult category and they don't feel the need to come back for their vaccination visits, or if they do come back for well visits, they might have a stronger say on whether I want to get this vaccine or that vaccine. So all those things, and sometimes even the parents and providers might defer it. So a lot of different implementation benefits of getting up to date by age 13. The focus, when you're younger, is still on, the cancer prevention piece. There's less hesitancy around any of those sexual initiation of sexual activity, or this vaccine could be a gateway to having sex and all those things. So again, I think there's a lot of evidence around, coming from survey research. We are also doing some survey research, that shows that, it is just, it's tremendously beneficial to get started early and complete a series early on time.
Great, thank you. For Sandy, how can clinics and coalitions and communities use the NIS teen data to inform the prioritization of the interventions that they're trying to do to increase HPV vaccination rates?
Thank you for that question. So I think I would think back to the three key points that I had at the end of my presentation. So I said, we've seen this is the second consecutive year that HPV coverage has not increased. So the steady increases that we were seeing before the pandemic, we haven't seen them in the last 2 years, and that's a problem. We want to be seeing those increases again. And then the coverage advantages that we were seeing among the VFC eligible adolescents for HPV vaccination, we're not seeing those anymore after the pandemic. And there might also possibly be a decline in the most recent youngest birth cohort. It looks like fewer of them are HPV up to date compared to our last pre-pandemic birth cohort. So those last 2 points say maybe to me that there is something going on with access to HPV vaccine. I think we've certainly seen in the news, heard anecdotally that it is becoming increasingly hard for some people to find pediatricians, to find their primary care. So maybe communities could and practices could remind families, remind them who is eligible for the VFC program. Communities could have other ways of getting adolescents vaccinated. In the MMWR, we mentioned school clinics or going to a pharmacy or other non-traditional places to get your HPV vaccine. So I think going back to those three key points from the data and thinking about the changes since the pandemic and issues around access.
Yeah, it's so important to remember that failure to vaccinate isn't always around lack of confidence. Sometimes
That's
there are
right.
very real access issues at play. For Stephanie, how do you think we can best help communicate about the duration of immunity from HPV vaccine and how amazing that has been shown to be?
Yeah, thank you for that question. So I think the best way to communicate is always just starting with the facts, right? We've seen this protection, and you can show families and providers, and we've had this data for a while, and the message just really isn't getting out there. So maybe, we have 114 people right now. If everybody shares with one person, we have doubled the number in a few minutes that know about this. So I just think continuing to spread the word about how we know how protective this vaccine can be. And it's even more protective if you get it at a younger age.
Excellent. Back to Sandy. Someone's asking about the gender breakdown from parents who complete the NIS team. Do you know what percentage are women versus men that respond to the survey?
Oh, I don't know the percentage off the top of my head, but as you can probably imagine, more mothers than fathers are completing the survey.
That would make sense. Okay, and one more for Stephanie. Will the immune protection be the same with HPV vaccine if it started at age 9 versus if it started at 11 or 12, do you think?
Yeah, I think from the data I presented, you could see that the younger age group actually had higher protection all the way up to 10 years than the older age group. So I don't think there's really a concern about we're starting the vaccine younger, that people won't have protection.
That's great. Yeah, we think about there's not a lot of vaccines where we've been able to eliminate doses over time. So it's nice to be able to offer folks one less dose of vaccine. One more question for you, Stephanie. Is the protection continued with one dose or with multiple doses? Can you remind us which data was used to look at that protection?
Yeah, so I showed data that started with the vaccine trial. So these were, they received all multiple doses. Do know there's a lot of research on what one dose could do, but I think that's kind of out still being considered.
Great. And I know there will be some discussion in the next ACIP meeting too, which is later this month, on HPV vaccine, and some discussion, I think, around timing and when dose. So that might be something that folks want to tune into later this month. Well, those are all the questions that we have so far. And so I am going to turn things over to Dr. Gabby Darville-Saunders to close us out with our celebration today. Thanks, Gabby.
Awesome. Well, thank you guys for inviting me to the party. If I could turn my video on. There we go. So I'm here to wrap up and facilitate our after party today. And I just want to thank all of our wonderful presenters, Dr. Sasena, Sandy Pingali, and Dr. Stars, for a well thought through discussion about the data surrounding HPV vaccination, where we are now, where we hope to go with age 9, and some of the immune benefits of starting earlier to get to on-time completion by age 13. So I know for all of you guys who are in the audience, who may be data nerds like me, you truly enjoyed that conversation in our panelist presentations. For those who may be struggling, it's okay. We will post a recording for these slides so you can get caught up to speed by next week. So as part of the wrap up for day 2, I have a lot of great announcements and rollouts to kind of explain to you. So next slide. So the first is going to be, if you want to know more about our efforts surrounding H9, last year we published our HPI special collection that has a collection of over 22 plus articles outlining the evidence and the data to support starting vaccination at age 9. We also have video abstracts that are available to help you learn more about the amazing research that our invited authors and authors have submitted to this HPI special issue collection. With that, we also have other resources on our landing page. So please visit our landing page, which I believe will be posted in the chat, that includes not only the HPI special collection issue, but also all of the other amazing resources like our fact sheet, our posters, our 9 for 9 video link, also our provider toolkit. That's all easily downloadable and accessible for you to use. Next slide. We also want to roll out today, dun, 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 dun. We have updated a few of our evidence summaries. So as you know, the Roundtable has been very proactive about providing evidence summaries on topic discussions that are relevant to you and your work. So we have some of our existing evidence summaries that are still available on our website, but we have a few more that have gotten a refresh update with new information and data to support your work. So a few of these have been linked to our website. These include our HPV vaccination starting at age 9, the effectiveness and safety of the HPV vaccine, school entry requirements for HPV vaccination, and of course, rural disparities in HPV vaccination. This is just the first of a slot or a compilation of evidence summaries that will be published in 2024. So please sign up for our newsletter and follow us on our website and social media channels to learn more about the updated evidence summaries that will be rolling out by the end of this year. We also want to thank our amazing member organizations. So we are now at 90 plus member organizations, many of whom you see on the slide in front of you. We could not do what we do without our members, our member representatives, the organization's leadership and buy-in to the work that we're doing as a national coalition leading the work in preventing HPV preventable cancers through vaccination. And so we want to take day 2 to say thank you, thank you, thank you. Some of our amazing organizations are also presenting and helping moderate our sessions during our 10-year party. And so we could not do all that we've done in the last 10 years without your efforts. And we look forward to continuing the progress with your collaboration and your innovation in the next 10 plus years to come. And lastly, we want to learn more about what you enjoyed in day 2. And so at the very end of this webinar, we will also be posting, and should post up for you, our webinar evaluation survey. So if you attended day 1, you got an email that included the link for day 1 evaluation. We're rolling out the evaluation day by day. So please go ahead and complete day 1 if you've not done it thus far. If not, let's focus on day 2 please go ahead and complete the survey. Let us know what worked. Let us know what could be improved upon as we continue in our daily series, our daily sessions as part of our 10-year celebration. We love to hear back, and we utilize your feedback in future planning as well as improvements to the programming that we conduct. Next slide. So tomorrow, we hope you can join us. We have a robust panel, so it is going to be a different structure for tomorrow. We have a panel of presenters that will focus on advancing HPV vaccination equity. Many of our panelists are included in this slide. You'll see essentially 2 sets of panel discussions based on the topics that we're centered on. We are definitely excited about our panel discussion for tomorrow, and we hope that you can join us as we explore how can we improve and continue to catapult HPV vaccinations despite some inequities and despite some disparities that may persist in the data, and how can we continue to make that progress that we've been making over the last 10 years. So we invite you to come back as we continue in our exploration and our celebration of the amazing efforts of our members and of our partners. Next slide. So thank you, thank you, thank you. We wrap up a little bit early today, giving you a few minutes back. But guess what? You have a few minutes now that you can dedicate to completing our survey. So we look forward to your feedback, and we hope you have a great remainder of your Tuesday.